antiarrhythmics. Antiarrhythmics is very famous. So for antiarrhythmics, you have to know different types of it. For you to understand the actions of antiarrhythmic, you have to read physiology on cardiac action potential first. Okay, left ventricular action potential. Please read this topic before you start your studying on antiarrhythmics. Please read the physiology topics on action potential. Okay, the phases of action potential and the corresponds to the ECG. So what is the threshold potential? What is the peak action potential value? From negative 80 at the peak, it go to positive 30 millivolt. What is phase 0? Influx of sodium. Phase 1 is transient influx of potassium. Phase 2 is influx of calcium and sodium. Phase 3 is influx of sodium. Then phase 4 is hyperpolarization. All these things you have to know. Okay, and your phase 1 correspond with where the peak of your phase 1 correspond with your QRS. So all these you have to know. So read on your physiology before goes to your antiarrhythmic topics. Okay. So once you have read it, then you know the different classes of antiarrhythmics acts at different phases of your ventricular action potential. So like class 1 is sodium channel blocker. So you see phase 0 here is influx of sodium. So your class 1 acts at the phase 0. It's a blocks in sodium intake. So you have 1A, 1B and 1C. I will go to this later. Okay. So class 1 is class 1, 1A, 1B and 1C. Then we talk about class 2. Class 2 is a beta blocker. It acts at the phase 4 here. And you have class 3, potassium channel blocker, which acts at the phase 3 where mostly potassium efflux happen. And class 4 is your calcium channel blocker, which works at the phase 2 where your calcium influx happens. So try to correlate, read your cardiac action potential in physiology and try to correlate which channel, which class of antiarrhythmic works at which phases. So this is my summarized notes with mnemonics to remember which drug goes to where. Okay. So the antiarrhythmics classification is Singh-Vaughan-Williams classification, or you're basically called a Vaughan-Williams classification. They always omit the Singh filler. So Vaughan-Williams classification. So it has 4 classes, type 1, 2, 3, 4. 1 got A, B and C. Okay. So type 1 is sodium, type 2 is beta, type 3 is potassium, type 4 is calcium. So how to remember? I remember as MBA college. Why MBA college? Sodium channel blockers are membrane stabilizers also. Then beta blockers, action potential widening is for potassium channel blocker and calcium channel blocker. But to remember it as sodium, potassium, sodium, beta, potassium, I remember nak balik kampung Cina lah. I also don't know why I made this mnemonic. Until now, it stick to me lah. Or you can make your own mnemonics lah. Okay? Or some block potassium channels or something like that lah. Come out with it. So sodium, beta, potassium and calcium. Remember, sodiums are membrane stabilizers and potassiums are action potential widening main effect. Okay? So class 1A, you have disopyramide, quinidine and procainamide. I remember as in ordering a McDonald's burger. Okay. So double quarter pounder, DPQ. Disopyramide, procainamide and quinidine. Okay. 1B is lidocaine, tocanamide, mexiletine and phenytoin. So with lettuce, tomato and mayo please. So this is how you remember lah. With lettuce, tomato, mayo please. Okay. Then 1C is morizizine, flecainidine and propafenone. More fries please and more fries please. So double quarter pounder with lettuce, tomato and mayo please and more fries please. So this is how you remember your type class 1 sodium channel blockers. These can be asked in MCQs, you know. Mexiletine belongs to type 2. Mexiletine is a group 1A antiarrhythmics like that lah. Okay. And beta blockers all have low propranolol, atenolol, everything like you all remember. I remember as PEAM lah. You can remember as Mia also. Initially, I was remembering as Mia, not Dr. Mia. Okay. Initially, I only remember as MEA lah, Mia, which is metoprolol, esmolol, and atenolol. But propranolol is included, so PEAM or whatever lah you want to remember. MAPE, MAPE or whatever lah. Remember. Okay. Class 3 is potassium channel blocker. We have amiodarone, dofetilide, sotalol, and ibutylide, beryllium, and all this lah. So a big dog is scary. A is amiodarone, B is beryllium, D is dofetilide, E is ibutylide, scary is sotalol lah. Sotalol is lol, but it does not belong to beta blocker. It belongs to group 3 potassium channel blocker. Okay, don't get confused. Just because there's a lol there, don't think of beta blocker. Then group 4 is your calcium channel blocker. You remember as very nice drugs. Verapamil, nifedipine, and diltiazem. Okay, this is the 4 group of antiarrhythmic but about by Vaughan-Williams classification. But this Vaughan-Williams classification a few limitations that has been heavily become controversial and has been heavily been debated. The main controversial topic is the most commonly used, few commonly used drug does not come into this Vaughan-Williams circulation, like such as the where they say a newer modified, which is an add-on, they say group 5 is DAM, DEM, digoxin, adenosine, and Maxalf. Most of the arrhythmia we use Maxalf, adenosine, and digoxin. The SVT you use adenosine. Digoxin you use in AF where your amiodarone can be given. So and your Maxalf and your adenosine. So but these are not included in this Vaughan-Williams classification. So this classification has been heavily debated. So that's why they come out add-on another class saying DAM for this. And then another main limitation is amiodarone actually can be goes into all 4 classes because it also has sodium channel blocking property. It also has a beta blocking property. It also has a potassium blocking property. It comes into all also. So you all Google up what is the limitation of Vaughan-Williams classification. There are 4 or 5 limitations. Please go through that also. The limitation of Vaughan-Williams classification. Please look through it. Okay. And then this important thing I've mentioned here, most of the MCQs comes with this, what is sinus arrhythmia? Sinus arrhythmia means tachycardia, increase in RR interval, bradycardia, reduction in RR interval, which is slower RR interval, marked on phases of respiration. Inspiratory rate, when inspiration, increase in heart rate. Expiration, decrease in heart rate. Not seen on exercise. All these are MCQs lah. Sinus arrhythmia seen on exercise, actually no. So these are the things you have to remember, few info lah. So as I mentioned, class 1A, 1B, 1C, and C. You can see the effect. Class 1A affects where? Class 1B affects where? Class 1C affects where? Class 3 affects at where? And membrane stabilizers. Class 1A, membrane stabilizers. So these are information that you have to know, but I have goes to, they see Vaughan-Williams classification. How about others? Adenosine, digoxin. This is where it does not fit into this classification. So what are the important things that can be asked regarding antiarrhythmic? First, they will ask about the, if sodium channel blocker, they will ask about the phase 0 slope, the effect of the class 1 antiarrhythmic on the phase 0, your phase 0. What happens in phase 0, whether it affects the phase 0 or not. Calcium channel, first group, usually it reduces the phase 0 slope. Okay, so whether it causes a moderate reduction, small reduction, and pronounced reduction. So 1C has the pronounced reduction. 1C, you see, pronounced reduction in slope. 1A is moderate and then 1B is weak. So 1B is weak, C is the strong, A is moderate. So strong, moderate, weak. Look at this. Strong effect, moderate effect, very minimal effect on the phase 0 slope. Can be asked in MCQ. Okay. Next, about the antiarrhythmics, we'll talk about action potential widening and action potential reduction. So we come to that. And then the uses you all can read here. And then about beta blockade, block sympathetic activity, it reduces the rate and conduction also. So about the action potential, you can see 1A increases the action potential, increases the effective refractory period. Your refractory period got effective, your absolute, and your relative refractory period. Your effective is absolute lah. It increases absolute. 1B decreases. 1A increases action potential, increases the effective refractory period. Your refractory period increase, your action potential duration also increase. 1B, it reduces action potential, reduces effective refractory period. 1C has no effect on this. This is also important. You see, one is about whether which one is the strong effect on phase 0. They differs, 1A, 1B, and 1C. And the effect of action potential also differs. One does no effect, one has increased, one has reduced. Try to absorb this. Okay. And then potassium channel blockade. Potassium channel blockade works at phase 3, where is the potassium efflux happen. They slow it. So what happened? What happened? They delay the repolarization. Your potassium channel, when potassium efflux, it causes repolarization. Yet your ECG corresponds to P wave, not the QRS. QRS is depolarization. Contraction is depolarization, DE. Repolarization is phase 3. So it delays the repolarization phase. So you increases. So it delays the heart rate. Okay. And calcium channel blockade, block L type calcium channel, not T type, L type calcium channel. Okay. Read through all this. Then again, I mentioned reduce the rate of phase 0, lengthen, shorten, no effect. You see, 1A, 1B, 1C. Lengthen, shorten, no effect. Highest reduction in phase 0, moderate reduction in phase 0, minimal reduction in phase 0. Look at the slope. And then class 2, predominant action on sinus node, because the beta blocker is sympathetic. Sympathetic is sinus. Okay. Class 3 is widened action potential. You see, it delays your repolarization. So your wide action potential memang get widened. And then class 4 is predominant action on AV node. Okay, AV node. These are all important things. Again, these are all repetition. Please go through it and try to link it with your physiology. Some will talk about PR interval, can be asked in some MCQs also, which increase the PR interval. So this is the whole summary of it. They talk about depolarization rate at phase 0, also given here, whether got effect or not. Then conduction velocity, refractory period, action potential widening, PR duration, QRS duration, QTC duration. You can use this table as a reference when you do MCQ. It gives the whole summary of it. Okay. Again, this is even extensive summary of it, where they also add on additional extra class actions. Okay. And then unique or potential side effects. And then common antiarrhythmic indication where they use it. So you can use it as a reference. So now we come to antibiotics. So antibiotics, again, a very dry topic where not many people like it, and it may get confused which one to use for which, unless you use it extensively, you are an intensivist or you are involved in the ID team, you use it very frequent, you remember it exactly. But other than that, for MCI level, you have to know which antibiotic are bacteriostatic, which is bactericidal. You have to know the mechanism of action of the group of antibiotics. Which group inhibit the folate, which is affect the cell wall, which one is inhibit the protein synthesis, which one affect the DNA synthesis. And then the next few common side effects, like a famous side effects of this antibiotic where you cannot start in certain patients. So this is how you go through antibiotic. If you want to read and memorize each antibiotic in detail, very difficult to mug up, and it's a very dry topic, you will get confused. I read my tea pack. One day I'll bring my tea pack. I've read my tea pack like more than 50-60 times lah. Every pages has been chanting, every pages has been torn. But antibiotic topic, the whole core antibiotic topic, I think it's very fresh, not even been highlighted also. I never touched it. Another thing is anti-cancer agents. These two topics lah. Oncology drugs and antibiotics, I don't read. It's like very dry topic. It's annoying to read. So these are the few how they affect. This is just introduction on your microorganisms, which is gram positive, gram negative. This is just introduction, not asked in Pharmac, but just remember when you talk about your antibiotics in your work. So your antimicrobials divided into bacteriostatic and bactericidal. Read about this, which comes to bacteriostatic, bactericidal. Some works at both. Okay. So you look at macrolides. Macrolides at low dose, they work as bacteriostatic. But high dose, they will work as bactericidal. Next, we go to mechanism of action. So, which affect the cell wall synthesis? Cell wall synthesis, your beta-lactam drugs. Your penicillin, cephalosporin, carbapenem, and monobactam. Vancomycin. And cell membrane effect is polymyxin. Polymyxin effect at cell membrane. Beta-lactam, vancomycin acts at your cell wall. Folate synthesis, which involve in your DNA, which involves sulfonamide and trimethoprim. Nucleic acid synthesis. Your nucleic acid synthesis got folate, DNA, and RNA polymerase involved. Which inhibit your DNA enzyme is quinolone. RNA enzyme is rifampicin R to R. D is quinolone lah. Okay. Then ribosomal activity. Ribosome, you got 50S and 50S and 30S for protein synthesis. What affects your 30S ribosomal synthesis is tetracycline and aminoglycoside. 30 is T tetracyclines. That's how someone remember lah. 50S subunit got 5 group. 50 for 5 group. So you have to remember these 5 group. Macrolide, clindamycin, linoleucine, chloramphenicol, and septogramin. Macrolides and chloramphenicol important to remember. Okay. Go through this picture multiple times. Try to draw it or try to list it out and then try to do it so you can remember it multiple times. Okay. Then this is my notes before I found this. This is again the same repetition of it. Go through it. Anaerobic cover, metronidazole, vancomycin, imipenem, clindamycin, unacin, moxifloxacin. All these have a anaerobic cover as well. Okay. And beta-lactam resistant drug, where you use beta-lactam resistant, where for beta-lactam resistant you use augmentin, ampicillin, unacin, and tazocin, flucloxacillin. Okay. Amoxi alone cannot be in beta-lactam. That's why you added clavulanic acid. Ampicillin, you add sulbactam for become unacin to use in beta-lactam. Tazocin is piperazoline plus tazobactam to use in beta-lactam. You use piperazoline alone cannot be. That's why you add on a tazobactam to overcome the beta-lactam inducers. Okay. Cephalosporins, important info in cephalosporin is cephalosporins got generation 1, 2, 3, and 4. We talk about Gen 1, 2, and 3. The important is generation 1 have higher positive cover rather than negative cover. Generation 1 has more gram-positive cover rather than gram-negative cover. But as you go below, generation 3 has more gram-negative cover and gram-positive cover. Generation 2 is in between lah. So the first generation, earlier generation have higher gram-positive rather than gram-negative. And the newest generation of cephalosporin have more gram-negative and gram-positive. Which comes in gram generation 1, gram generation 2, gram generation 3. You all can read yourself. Then few other mnemonics. This is just for you all to either, if you're a person who remember mnemonics, you can remember, or you just for your reference lah. Protein synthesis inhibitor, they give almost there are few things. Okay. Then commonly side effect, antibody side effect. Few of it you must know. Penicillin group, the main thing you know is allergy lah, hypersensitivity allergy. Some of them even cause Stevens-Johnson syndrome. Okay, read about that. Then your clindamycin, main thing is pseudomembranous colitis. Okay, aminoglycoside is ototoxic and neurotoxic. Okay, ototoxic, nephrotoxic, and neurotoxic. It's ototoxic because it cranial nerve. Okay, vestibulocochlear nerve. And then damage to kidney because nephrotoxic. That's why used in ESRI patient. Metronidazole can cause GI disturbance, diarrhea, and seizures. Vancomycin also cause vestibular toxicity and thrombophlebitis if extravasate. Chloramphenicol, bone marrow suppression. Patient can go into aplastic anemia. Erythromycin, GI disturbance. Tetracycline, tooth discoloration and photosensitivity. Again, few other things mentioned here. Important here is this one. Linezolid can cause serotonin syndrome. Isoniazid, peripheral neuropathy. That's why we give what? Pyridoxine in a patient who has anti-TB. And macrolides can cause QT prolongation like azithromycin, erythromycin. That's why we check your ECG before we start erythromycin. Tetracycline, teeth discoloration. Okay. And vancomycin, red man syndrome. Again, important. Okay. Red man syndrome. Again, few other thing. Again, trimethoprim, Bactrim can cause hyperkalemia. We always look in ICU, right? And your sulperazone can cause coagulopathy. Okay. Sulperazone lah. So all that. And loop diuretic. These are few other things lah. Few common drug effects and then nitrofurantoin, brown urine sometimes asked. Metformin, you all know it causes lactic acidosis. AC inhibitors cause you to have dry cough and angioedema. Phenytoin causes gum enlargement. Methotrexate can cause mucosal damage and also cause DNA involvement, cause subacute degeneration of spinal cord. These are the few things lah. Okay, this is for your reference. Okay. Next we go to inotrope. I'm not gonna talk about each and individual topic on inotrope. the one I talked in that ICU course that day, not that. I want to give few information for you to remember the receptors and also which type of receptor. That day when I talked for non-ICU MOs, I didn't talk in detail about G protein coupled receptors. You have GQ, GI, and GS. For your level, you must know in detail what is GS. GS stimulate, GI inhibit, GQ is phospholipase. So you have to know in detail which sympathomimetic acts via which G protein coupled receptors. G protein coupled receptor not only for sympathomimetic. Opioid works via G protein coupled receptors. A lot of other drugs also works via G protein coupled receptor. Your GABA also, or some of your induction agents also works via your G protein coupled receptors. So I'm going to talk about inotropes. I'm going to work this part. I'm not going to go through. You all should know this is a basic of it. What alpha receptor and subtypes of it. Where is it located and what is the action when it gets stimulated? Read on your own. We have alpha, beta, D, and vasopressor. I'm going to talk about G protein coupled receptor, how to remember which works via which. The mnemonic is KISS. Okay, you have alpha 1, alpha 2, beta 1, beta 2, beta 3, D1, D2. Your alpha 1 works via GQ. So you must know how the GQ receptor works, phospholipase C and IP3, inosine phosphate 3, and your phospholipase C lah, your creatine kinase and everything. Alpha 2 works via GI. GI is inhibition, reduces your cyclic AMP. GS increases your cyclic AMP, stimulator. Okay. Then beta 1, beta 2, beta 3, and your D1 works via GS. Alpha 1 works via GQ, alpha 2 works via GI, and D2 works via GI. KISS. This is my mnemonic for me to remember this. In MCQ, if they ask dopamine D1 receptor works via GS, G protein coupled receptor, false. You must do your mnemonic and remember it. Okay, this is the simplified form. So that's all about inotrope. Another thing, this dopamine and adrenaline have both beta and alpha effects, right? Beta effect at low dose, alpha effect at high dose. Blah lah. This is how I remember. I will give a lot of mnemonic. I'm a person who remember pharmacology with a lot of mnemonics lah. There are a lot of people doesn't fancy that, but up to you. I give it to you what I think is good methods to remember or read. Up to you to take it or leave it. Okay. Or you can change the mnemonic according to your preference. So next we go to other tips. Other few things that you must remember. Beta blocker, another common topic asked in MCQ about their contraindication and about their cardioselectivity or membrane stabilizer property. If you read your beta blocker and podcast, they will start off with this, whether they are cardioselective or not, whether which has a partial agonist, which has a membrane stabilizer effect. So this is the cardioselective, again MEA lah, MEA, which is esmolol, metoprolol, and atenolol. Okay, and beta blockers mostly cross placenta or BBB. That's why you don't give in pregnant patient because it can cause fetal bradycardia. You don't give in pregnant patient or in a lactating mother. Partial agonist is timolol and pindalol, famous. Membrane stabilizer are propranolol and sotalol. Propranolol goes to group 2, antiarrhythmic. Sotalol group 3, antiarrhythmic. Beta blocker contraindication, I remember, is A, B, C, D, E, F. A for asthma and atherosclerosis, we don't give. B, it can cause bradycardia, it means patient with heart block, you don't give beta blocker. C, in congestive cardiac failure and COPD patient, again, you don't give beta blocker. D, in a patient who have severe DM or uncontrolled DM, if you give beta blocker, it can mask the hypoglycemic symptoms. So you see, in a patient with DM and hypertension, for those who are not uncontrolled, very rarely we start beta blocker for their hypertension. We will give amlodipine, we give hydrochlorothiazide and everything. We don't give beta blocker because the beta blocker will mask the hypoglycemic symptom. When a DM patient is on subcu insulatard or the atrapate or oral hypoglycemic agent, if they are overdosed and they didn't take their meals, they can go hypoglycemia. What are the symptoms of hypoglycemia? You will have tachycardia, you will have sweating, you have palpitation, but beta blocker will mask all these symptoms. It will prevent the tachycardia, it will mask your sweating, it will mask your palpitation. So patient will go into hypoglycemia without any symptoms and will go into hypoglycemic coma. So that's why we avoid it. E is erectile dysfunction. Beta blocker can cause erectile dysfunction and is also extremities in peripheral vascular disease. It can cause problem. So atherosclerosis, same thing lah. And finally, fetus, it is avoided in pregnancy or lactating mother. Okay. Next would be talk about, again, this is another mnemonic I find. If you want to remember, ballfish also can lah. So it's the same as ABCDF, but they gave in a different things lah. Okay, you all can look at it. Amiodarone, super famous in pharmacology. Its action, its side effects, the mechanism of action, which class of antiarrhythmics and everything. So few things remember amiodarone. Amiodarone belongs to all 4 class of antiarrhythmic. It can works in all 4 class. That's first thing. And amiodarone side effects and where it is contraindicated, it can prolong the action potential. Okay, so it can patient turn to bradycardia. That's why when you start amiodarone bolus or maintenance, you must tell the staff nurse if the heart rate goes below 60 of the amiodarone, do not continue. Patient go into severe bradycardia. Okay, photosensitivity, patient with lupus, patient with SLE flare and everything, we avoid amiodarone. Pigmentation, it can cause skin pigmentation if you use in long term. Peripheral neuropathy also can happen in a patient. So a patient will come with peripheral neuropathic symptoms. Those who already have some neurological deficit, you are aware. Pulmonary alveolitis and fibrosis, patient with pulmonary fibrosis, we avoid amiodarone. Those who have a very stiff lung, you cannot use multiple doses of amiodarone, can cause fibrosis. And then very importantly, it inhibits peripheral T4 to T3. T3 is your active chironin, okay, active thyroxine. So you need this, but amiodarone inhibit this. So patient will go into hypothyroidism. So that's why when patient have goiter and we don't know about the patient's thyroid status, we will get avoid amiodarone. Okay, patient AF in a thyroid storm, patient comes, you don't know, you will avoid your amiodarone. Next is porphyria, again famous. What are the drugs can induce porphyria, acute intermittent porphyria, by inducing or disturbing the enzyme porphophylinogen deaminase. Read pharmacology on porphyria. When you read about porphyria, firstly, when you read sodium thiopentone, they'll talk about porphyria because sodium thiopentone is a it's an inducer, famous inducer for porphyria, especially. Acute intermittent porphyria is not a disease of Asians, it's a disease of Westerner. Overseas, they have a lot of them with AIP, acute intermittent porphyria, because the defect in the porphophylinogen deaminase. You have to know how porphyria metabolism occurs. You have to read in podcast or the TPAC. Then you will know where this enzyme comes into play and how these drugs can interfere with it. The mnemonic I have is stop RBCL. Why I mentioned RBC? Your porphyria is one of the heme production in your RBC also. So these are the few drugs to remember. Please go through it. You can use it as your reference when you do MCQ. Lupus, again, SLE inducers. What are the drugs can induce SLE? CHIMP. I don't know why I created all these mnemonics lah. So remember this, use as your reference. Then this is another famous, and of course, I think you have come across this lah. What are the drugs that can induce the enzyme or inhibitors? Sorry, I forgot an R here. What are the drugs that induce an enzyme? What are the drugs that inhibit? These are hepatic enzymes. Your enzymes, your hepatic metabolism cause oxidation, phase 1 oxidation, phase 2 reduction, right? Oxidation and reduction, right? And conjugation. So what are the drugs that inhibit and induces this? These are all enzyme inducers. These are all enzyme inhibitors. So you have your gap price. You get your inhibitors is VMCI fit cake. I don't know why I might come up with this lah. But in exam, it helped me a lot lah. Whenever the question asked about inducers or enzyme in the in a paper, I just write all this. I just write the gap price. I see the drugs that given in the MCQ comes into this or not lah. So please look at it. Okay, these are for your reference. Next, again, just now when I was looking for few slides, I actually come through this website Pharmac. They give a lot of mnemonics lah. I didn't use this mnemonic. I just found it today in the website. Up to you all lah. You all want to look at it or not? I just put it up here. Again, many of it. Captopril. What are the common side effects? Cough, angioedema, photosensitivity, taste change. Potassium will increase hyperkalemia in a patient with AC inhibitors. Can cause renal impairment. That's why we don't usually start. Can cause itchiness. Patient can go orthostatic hypotension, low BP. So captopril is famous. Calcium channel side effects also very famous. Fatigue, increase in glucose level, it can cause hyperglycemia. Edema, amlodipine causes fluid retention and causes edema, and all these things lah. Okay, and then your SSRI, again few things like I didn't use this all. Captopril, yes, I have this mnemonic of captopril. I used it. This all I just found today. Okay, that's all for today.